Yep,
Here.
we can hear you just fine.
Good.
Yeah, and good afternoon, everybody. We will be starting up here shortly. We'll let, I don't know, Megan, if you or Becky was going to start it, and then I'll do the introduction to Amy.
Eric, how about you get us rolling with introducing Amy? Goodness.
Okay.
I don't know how much speaking I should be doing today.
Yep. Well, let's get going. Good afternoon. Good to see everybody on. My name's Eric Boyer. I'm the Senior Program Officer here at the Alaska Mental Health Trust Authority. And it's great. We've got 37 folks signed on. I think a lot more will be jumping on in the next few minutes. This is a Crisis Now webinar series that we're getting support from RI International and Agnew Beck. And it's part of an effort just to really, I think, up the knowledge and how to implement some of these services in the state of Alaska as we work with all of you across the state at different levels, different phases of the implementation of some crisis stabilization services. So excellent to see you all on, combination of providers and some of our friends at the state of Alaska. And this is being recorded, and we will have this available for you to watch at another time or for your colleagues in the field. So without further ado, I want to maximize our time with Amy, and I'm just going to do a short intro, and then at that point, I'll pass it over to you, Amy. We've been working with Amy Pugsley and her colleagues at RI for the last several years, and they've been really instrumental in providing that kind of technical expertise and ability to really think through a best practice framework like Crisis Now and the real work that they do in other states with this model and how that can look here in Alaska. And that is, you can ask our friends at Providence and South Central Foundation and True North Recovery and other places like that, that they really find the value in that. Oh, and I just see Tracy turned her video on. Tracy Dompling down at Bartlett Regional is another of our peeps in the field that utilize an Agnew back in RI. So Amy is the Executive Vice President for RI International and currently oversees the operations for multiple states, RI's Quality and Compliance Department, and consults in several areas of organizational development, leadership development, improving financial sustainability for programs and communities. Amy's been in the behavioral health field for over 25 years, worked a variety of capacities. I know for many of you, this sounds familiar. It sounds like your own life, right? All the different capacities you've done in behavioral health. She's worked in outpatient, crisis service, residential, operations, and administration. She joined RI back in December of 2015 as the Director of Quality and Compliance and worked diligently to rebuild a strong foundation for the agency in continuous quality improvement and corporate healthcare compliance. Before that, she worked for Southwest Behavioral Health. She was a regional program director there in Arizona, and she oversaw 3 outpatient clinics. She's got a background in behavioral health. She got her licensure in Washington State, worked in children and family services, worked for the Attorney General's office, and she also worked for Service Alternatives in Washington as a program manager for home and group home programs. She got her bachelor's degree in developmental psychology from Central Washington and her master's degree in mental health counseling at Argosy University in Seattle, as well as a master's in business administration. She has her certifications in corporate healthcare compliance, Lean Six Sigma, and mental health first aid. And on that, we'll pass that over. But if all of you that are on, while Amy cues up our recovery-oriented webinar today, if you could go ahead and just put your name and where you work in the chat, that'll just allow everybody on here to see who each of you are. Some of us we know really well, but some of you we might not realize what organization you work for or what part of the state you're from. So that would be super helpful. And with that, Amy, thank you for taking the time today and coming to help us learn more about recovery-oriented care.
Thank you. Thank you so much. And thank you got a hold of my bio. Thank you for that nice introduction. But I will say that it probably does sound like a lot of all of yours as well, right? This is what we do, is a variety of different things constantly throughout our career. And before we know it, we've got 20 plus years doing it all. So I'm very I've had a very blessed career, so happy to be here with you all. And I'm going to turn this into presentation mode. Please let me know if you all can still see this, and does everything look good?
Yep.
And you can hear me good?
Yep.
Okay.
Presentation mode looks great.
Okay, excellent. So, so today, as many of you, you might have been on some of the other webinars that we've gotten as well. And today's topic is really about how do we create and maintain a recovery-oriented environment. So we talk about recovery-oriented work a lot. And in the Crisis Now model and the national guidelines, it lays it out really clearly for us that this is a key component, an essential principle in being able to really help individuals in the way that we want to help individuals, right? The way we want our family members to be served, the way we would want to be served and treated ourselves if we were receiving services for a crisis. And so, so when we were kind of going through these monthly webinars, we felt like it would be really good to take some time out to think about, what does this mean? And when we say recovery environment, we're going to focus a lot on the actual facility itself. However, I do want to touch base on all those different elements of the crisis continuum as well, because it needs to be recovery oriented and at all levels. And so that'll be the goal as we go through today. And so just as a reminder, the Crisis Now and the national guidelines that SAMHSA put out, really there's 3 core services. As you all know, you're working towards these in Alaska right now. And really it's that call center hub, someone to call, crisis mobile team, someone to come to you, and then a crisis receiving center, which is a place to go. And at all 3 of these levels, it's really important that we have these recovery principles in place. And so this is straight out of the SAMHSA national guidelines that we helped write, that were released back in 2020. And the essential principles for an effective crisis system is really about addressing recovery needs. And I always say at every service level. So addressing recovery needs is what you'll find in the document, but I always say at every service level, because it's really critical that the person that's answering the phone at the call center is doing this as well. The person that's responding to someone out in the community is also doing these things. Having a significant role for peers throughout the entire system. So sometimes one, not everybody understands or has fully embraced that peer support specialists are absolutely the secret sauce to making all of this work and work well. And then what I often see in systems is that they understand that component at the facility level, but maybe not at the call center and the mobile team level, or they understand it at the mobile team level and facility level, but not at the call center level. And so really just making sure that that is a people with lived experience are a part of the entire system, and that we're looking through that lens continually. A trauma-informed care environment. And this is something that we really talk a lot about around that it's not just a trauma-informed care training, that often all of us, we probably count on multiple trainings that we've been to around this, but how do we really create a trauma-informed care environment that everything that we do, from answering that first call to serving someone in a facility, is trauma-informed at every layer, and that our staff are feeling that as well on their side of things as well, as far as taking care of themselves. Suicide safer care. So really making sure that we're utilizing these tools, whether that's through assessments and all of those things, versus as well as the environment itself. Safety and security for staff and individuals in crisis. And so understanding that that has to be a key component, and a recovery oriented environment doesn't exclude those things. It embraces that. And that's how we make sure that we're ensuring a recovery oriented environment. And then really a critical principle, as you all know, is the crisis response partnerships with law enforcement, dispatch, and emergency medical services. So those are the key principles that are laid out in the Crisis Now and national guidelines, and really help feed into the recovery-oriented environment. So when we take a look at the call center hub, I just kind of broke down a couple of these for the call center and the mobile crisis, just to give one slide on each that talks about how can we make those systems recovery oriented as well. And so staff with trauma-informed and recovery-oriented teams to answer all calls and provide the needed assessment and support that individuals need during their time of crisis. So really understanding that crisis, and those of you that are in the crisis line, crisis call center side of things, really understand this and could probably teach on it much better than I could. But the idea of being a trauma-informed environment for both staff who are receiving this information of people in crisis and the trauma that happens from just hearing that information, and the compassion fatigue and all those things that play into being a staff member that's receiving that information. And how do we really wrap ourselves around our teams so that we're supporting them in that way as well? And how are we being able to deliver that information over the phone in a very trauma-informed and recovery way? And that's the language that we use. So the next one is really training that people are utilizing recovery language. And one of the things that I would say that that I have noticed, a lesson learned from doing this for so many different programs and overseeing the operations of those programs, is that one, it's extremely important to teach this, because it's not common sense, not common knowledge, not something that comes naturally to people as we would think that it would. And so making sure that we actually take some time and teach and train staff on recovery language. But then the key part that I always like to really bring up is that staff are using and expected to use recovery language all the time, not just while they're on the phone with a guest or in the facility with a guest or out on a call, but when they get back in that car or they hang up the phone and they're talking or debriefing about what happened, that we still remain recovery oriented and are using recovery language. And I would say that the reason why I've learned this over the course of years that I've been working in the field is that what I see is that you really know who your people are that are very committed to the cause, very much want to help individuals, versus someone who's doing a job. And you need people who don't just want a paycheck, but that really care about the work that they're doing. And so being able to kind of have this as an expectation throughout their entire work day, whether they're actually speaking with a client or a guest, or in the facility engaging with a guest, that they are carrying this out in everything that they do, even in the staff break room and in trainings, or when they're in the front office talking with someone or with their supervisor debriefing over a situation. This is a really important thread to have embedded in everything that we do at all levels. And the next piece for the call center is really important, is that staff are cared for as well during the challenging work that they do. So this, and you guys have, any of you that have toured Solari, which is the call center in Arizona, and possibly even your own call centers have this, but really having the ability that all staff have the ability to access their supervisor anytime they need to throughout the day. And that they're dedicated, the supervisors are dedicated to being there for them. So they're not doing all this administrative stuff where they have to kind of take time and put people on hold, but they can respond, get on a call, listen in, do all those things right away, because that support really helps encourage that ongoing recovery oriented environment. The ability to debrief calls, which is usually a natural part of everybody's process, but I feel like it's worth saying. The ability to take breaks when needed. The work environment is recovery oriented itself, so it's set up in a way that is helpful for staff. So if they want a standing desk versus a sitting desk, if they need one of those balls to sit on instead of a regular chair, if they need things that they can, decorate their cubicles to make it more their own, things like that to help them get through the day that they have, as well as, and I mentioned, if you've toured Solari, you'll see that they have actual spaces. And I know that through the work that I'm doing with you all, South Central Foundation and Providence in particular, you guys are also taking these things into consideration, where you have not only a staff break room, which is obviously really important, but some other kind of either a meditation room or a calming room. In Solari, they have a fitness room. So they have the ability to they can go on the treadmill, they can ride a bike, they can do some other things that help keep them active while they're on break to just clear their mind and move on to the next thing, as well as a gaming and entertainment area. And that seems counterintuitive because we want people to do the work that we want and we don't want them to have, but having the break in there and just being able to kind of think about something else or not think at all maybe for a moment and then come back to what they're doing is really critical. And so so those are some key ideas that I think would be really helpful for that call center hub. For the mobile crisis teams, very similar, but making sure that, of course, it's a 2-person team for sure. And the way the national guidelines really outline it is that it's a clinician and a peer support specialist. There's a reason for that dynamic that we want. And so ensuring that that's part of the process that you guys have or that you're setting up, that staff have the ability to reach supervisors during these challenging situations and that they are able to take a break. So one of the things that we've learned from our partnerships with the mobile crisis teams in Arizona is really, I apologize, there's some noise in the background, is really being able to not have a place for staff to go, whether it's a designated office spread out at different offices or a that they have, you know, some place in the community that's not the car. So when you're out and you're being a mobile team, right, especially if you're in a rural area, it might be very just kind of makes sense or accommodating for them to take their breaks while they're in the car and that type of thing. But really what we found in the feedback from staff in these mobile crisis teams in Arizona has really been, they need a place where they're out, they can get out, take some breath of fresh air and those types of things. So being able to designate those, whether that's through partnerships, you know, there's an outpatient facility that's close to where they are. Can they have an office that they just come and take a break in and set up like a break room type thing, but thinking through what those things might look like. And then the van setup, which is really important, is really thinking through that they have the supplies that they need for both staff and for guests. So common things obviously are first aid and infection control type stuff, but really making sure that they have water and snacks, that they have the ability to offer the guests that they're picking up some opportunities for like blankets for emergency situations in Alaska. You guys might think of some other things that would be really relevant for them to have in the vehicle in case something is needed, right? And so being able to do that, because one of the things that we want is the recovery oriented environment for the people that you're serving out in the community, but you also want your staff to have the resources they need to help them when they feel like their hands are tied and they don't have all the resources or don't know if they can give away that blanket or that type of thing. They feel less able to do their job, which then really kind of has a counter effect on them doing their job well. And then vehicle safety equipment, GPS tracking, and those types of things. And so then the rest of the time, we're going to really focus on what these receiving centers really should look like and that environment as a whole. And really making sure that we're designing a space that is very safe, home-like, welcoming, and calm. And that is not an easy task. And those of you that are going through design plans right now can probably agree with me, is that that it takes some doing to figure out how to make sure that we have appropriate workflow and efficiency for staff, but also have good natural lighting, some ability to put some soundproofing on the wall so it's a calming instead of echoing, and then being able to set up furniture and the spaces for people to sit in a way that is more home-like you're sitting in a living room, right? A lot of this is based off of that living room model, and being able to even though they're in crisis and all the furniture is anti-ligature and safe and all of those things, but setting it up in a way where it's very warm and calming. And then also additional is evidence-based and trauma-informed care for staff and their training, role-specific training, And this is really important, is to make sure that the staff that are doing their jobs understand their scope of work, what they're supposed to be doing, but also are cross-trained so that they know what their peers are doing as well. And so then if everybody knows, then they can count on them and they're less likely to kind of overstep. And so really making sure that that training is good, as well as staffing ratios for amount of staff to clients and guests being served is appropriate for safety measures. That's the number one thing that you'll hear from staff. If they feel unsafe, they will let you know, as you guys probably running any facilities or hospitals know. And so making sure that that's consistent. Making sure that the environment is non-institutional. So we don't want it to look like a hospital setting in the crisis settings, but we want to make sure that it's a welcoming physical space and environment for people. No plexiglass, no barriers on the, sometimes people call them the nursing stations. We call them a staff island because it's for all of our staff, but no plexiglass, no fishbowl, no doors that people have to go through, but they have direct access to staff constantly all the time. There's no barrier between staff and the guests that we're serving. Obviously anti-ligature. And again, this is something that, and we'll, as we show pictures and the video, you'll see that there's a way to be able to make sure that everything is anti-ligature and safe like a hospital setting, but done in a way that is very recovery oriented and living room environment type. And then another one is the no force first philosophy. And so really identifying, now, I always like to stop here and say, no force first doesn't mean your staff aren't well trained in restrictive interventions, and that you have a seclusion room in the facility. All of those things are important and really must as we go through that. And the reason why I say that is because we have definitely learned over time that when staff are better trained, they actually use restrictive interventions less. So the more that they feel like they are equipped with what they need if a situation were to escalate, the less likely we see that our restrictive interventions go down dramatically. And in some programs are rarely even used at all. Like really, like once a year, they put hands on anyone. And so this idea of no force first philosophy is really important. It's got to be the core of what we're doing to have it be a recovery oriented environment. However, that doesn't mean we don't train and that we don't have the seclusion restraint room as an option. There are many people that need that, and just having the option of a seclusion room means that it just helps staff feel safer. When they feel safer, they're more likely to just do their work, and knowing that that's a possibility if they need it. They don't resort to it like sometimes people think that if they're trained, then they're going to use it more. What we found in all of our data across all of the states that we work in, that's actually the reverse. Better trained, less use. So just something to think about as we go through that and you're building your own. And then staff with a multidisciplinary team to include the variety of people that we've talked about before, but nurse practitioners, psychiatrists, nurses, clinicians, peer support specialists, and behavioral health techs. And the reason why that dynamic is so important is because that is how you really engage individuals in crisis, because most of the time it is going to be the peer support specialist that has the best, initial interaction and all of that. But sometimes people want to talk to a nurse. They know a nurse is going to be able to help them. They look at nurses or a nurse practitioner or a psychiatrist in a specific light, and they want answers from them. And so that's going to help calm them. So you need the entire team to be able to effectively have a recovery oriented environment. Okay, and so I'm going to show you guys a video, and Becky, I don't know if you got my message, but I was hoping that maybe you could show the video real quick for me, if that's possible.
Yes, I think Megan has it pulled up, and so I'll ask her to go ahead and share her screen.
Okay.
If you can, great.
Perfect. Thank you.
And for folks that have your videos on, if you have trouble, hearing or seeing the video, you may want to turn your video off just to conserve bandwidth on your end. So thanks, everyone. Megan, I'm not getting any audio.
Sorry, say that again, Becky. I couldn't.
I'm not hearing anything. No audio.
I might need
Megan, when
salt.
you share screen, you have to check the box where it says share sound also.
Thank you. Let's try this again. Oh, 1 sec. Someone from my team come rescue me.
Click share screen.
Mhm.
Select your screen that you want and then show where's okay, X out. Okay, select the up arrow.
We'll get this rolling in just a minute. Amy, thanks for your patience.
Oh, no worries. We got plenty of time. It's good. Thank you.
Every community in the country has people that are currently in a mental health crisis. Too often, these people are turning to using hospitals, law enforcement, substance use, and even suicide to manage the overwhelming situations. They can also be wary of getting support in a crisis if it means overnight care in a facility. But there is a model for how crisis can and is being delivered effectively in a least restrictive setting. Crisis facilities are a starting point for those that have never accessed services before or need additional support beyond their current services in time of a crisis. Three key elements of the Fusion model make it different from typical treatment facilities. The physical layout is an open floor model. Staffing significantly features lived experience, and there is a substantial impact on the community. In the mid-1990s, Recovery Innovations began hiring large numbers of peer supports and launched the first crisis living room model just outside Phoenix, Arizona. Crisis Fusion facilities are seeing and supporting people 24/7 and don't turn anyone away. They are available to anyone seeking assistance for a crisis situation. Fusion facilities are multidisciplinary as they use peers, therapists, nurses, doctors, and NPs to make it all work. They work using a team approach with every guest, so decisions are made together. At this Phoenix crisis facility, law enforcement is responsible for more than 80% of the referrals. Over the past 4 years, more than 13,000 individuals have admitted to this crisis urgent care center by police. But none of those had to go to the emergency room to wait. Despite a very high acuity, individuals are greeted by a caring peer support orienting the person in distress to care. They are referred to as guests and not patients or consumers. In 2010, Optum Health replicated this model near Tacoma in the view of Mount Rainier. This center provides warm compassion and high engagement when a consumer comes in. The walls are painted and decorated to encourage positivity and recovery through the use of murals and guest artwork. Here, the welcoming setting is not exclusively indoors. The outdoor patio overlooks a reed pond where guests can connect with others. Funders start these programs to decrease costs, reduce incarcerations, and improve recovery for those they serve. But change can be hard. In Delaware, a lawsuit from the Department of Justice provided the Department of Substance Abuse and Mental Health the opportunity to implement this fusion model in 2016. About 1 in 4 staff are certified peers. Peers are employees with lived experience and provide valuable social and emotional support during their journey. peers are the first and last person guests see during their stay. They are the overwhelming proof and a reminder that recovery works, spreading the message of resilience and hope to all guests that are struggling. In 2016, the team at Atrium Health opened the Mindy Ellen Levine Behavioral Health Center just outside Charlotte, North Carolina. This crisis facility features peer staff, trauma-informed care, and a setting that is unparalleled. They have committed to creating positive, nurturing environments, minimizing the possibility of traumatizing the person in distress. This includes providing services in an inclusive and person-centered manner, using non-coercive support strategies. Their space resembles more of a home than a state hospital, communicating that a person with mental health or addiction crisis matters. The Fusion model says we care before even entering the building. Even in the secure Sally port for police drop-offs, the design team thought about trauma-informed care and safety at every step. In 2017, Riverside County and Southern California took the Fusion model to its highest level yet, inside a campus of care. Their prior facility, which opened in 2015, was temporary, but the change was dramatic nonetheless. Inside and out, this Fusion model welcomes and heals. This space was designed for recovery. The furniture is arranged to promote connection. The layout provides the ability to receive private and individualized support. The staff is able to connect with persons in distress and stay with them until they feel safe again. When these settings are staffed with individuals who care, who actively engage and collaborate, distress is calmed, crises are stabilized, recovery plans are activated. The Fusion model strives to provide services in a safe, supportive, recovery-oriented environment. This isn't the future. The Fusion model is today.
Excellent. Thank you so much for showing that. Your bandwidth was probably much better than mine has been, as I'm at a conference today. So, okay. And so the reason why I wanted to show that video was that there's obviously some pieces in that around the Fusion model and this multidisciplinary team, but it's a really good video to show different facilities operating with a recovery-oriented environment in the design of the facility, and that it doesn't have to be like a one way, right? It doesn't have to look all the same way in every facility, but that we're taking into consideration the location and what's around that area, and then utilizing that space. So if there's an outdoor space that can be created, that's extremely beneficial, but understanding how to do that safely. And so it's really important to think through those things, because the design and the layout not only is going to create a safe environment, which will lend to the recovery oriented environment, but it also will create a space where people are not, it's some place that you would want your loved one to be served in. And that's always the piece that I always say, the kind of the barometer that when we're designing facilities, I always ask people when they're, when I'm working with them, is this somewhere that you would want your mom to go? Is this somewhere where you would want your son to go or your daughter to go? And if yes, then we're moving in the right direction. If no, we need to come back and make some tweaks around that, because you can have both safe and recovery oriented, that's warm and welcoming and therapeutic, with the goal of helping individuals come out of that crisis and stabilize and move to a least restrictive environment as possible. So hopefully, that video showed some ideas for you all. I also have some slides of some different pictures, and I wanted to go through these to help hopefully kind of do some brainstorming and thinking if people have questions and things like that at the end. But one of the things that I would say is a very important design factor in the environment of the facility base is that it's a very open space. Even if it's bedrooms, right? The short-term stay and there's bedrooms, but the bedrooms are along the wall, and the space in between is very open, that there's no hallways or blind spots as much as possible. In addition, that we're setting up the furniture, and we have a variety of furniture. So in here we have some recliners. I don't know why it took me so long to figure out that rockers would be very therapeutic on a crisis unit, because I love rocking chairs, but it did. And so now for about the past 3 years or so, we make sure that our designs and our furniture always include rocking chairs. People are just very, they're comforted by the ability to rock in whatever situation that they're in. And so having a variety of different furniture and how it's set up is really important. The mural on the back there that you see in this slide is also something that we take very seriously, is the paint and the color on walls is incredibly important. It's hard to have a lot of kind of artwork or things like that that you're securing to the walls, because you don't want things to come down or get broken and things like that. And we actually have a peer support specialist. Her name is Lucy Schwartz, and she is a very talented artist. And so we had her create these, and she actually flies around to all of our different locations to put murals on walls. And in these murals, they have recovery language. So I think in the video you saw the raccoon, she also painted that one, but there's recovery language that's embedded in there. And what we get more overwhelmingly on our kind of guest satisfaction surveys when people are leaving our facilities is how much they enjoy the paintings that are on the walls, and that it's not just kind of a sterile one color type painting. So I really encourage people to, yes, that's the simple way to do that, even if it's a very calming tone in color, but to add and think through how can you make the walls kind of come alive and be a very warm and welcoming place as well, to help the environment as a whole. And that's one way to do that. Here's another example of our facilities, and I really wanted to highlight here. So different tones, right? So this is a little bit brighter tones than some of the softer tones. So again, it doesn't have to be one way. It's really whatever we're thinking the population that we're serving is going to benefit from. And if you look, it's kind of hard to see, but outside those doors and windows, there's a outdoor space. And I will say outdoor space is sometimes hard to come by. It is in this facility. And so in this facility, what we did was we recreated an outdoor space with material that kind of looks like stained glass, but it's not glass, around, so that it's private for the individuals going out. And then we laid down turf so that it felt like that they were on grass rather than, a cement concrete area. And so just another thing to think about as you're designing outdoor areas, and making sure, obviously, the weather is really important. In Arizona, it's very hot. We have other states that we have a lot of snow. You guys have a lot of snow or cold weather that we'll have to think about, and how to design that outdoor space so that it's still welcoming and therapeutic for people, because outdoor space is really important for them to get fresh air. And but then also the design of this different pods, if you will, of furniture set up so that we're encouraging engagement, not chairs in a row, not kind of this assembly line of people. We don't want that look at all, but we want to encourage by even setting up our furniture in a way that it feels very much like a living room. And that when people are sitting down, taking a break or thinking about things, that they can not only engage with staff at these locations, but then also engage with each other, which is extremely important as well to help in their recovery. Here's another design, and this is the blues and grays. So the other was a bit brighter. This is a bit softer tone. And this is our facility in, well, this one actually I think is in Baton Rouge, but we have the same design in our Washington facility, our new facility, with these blue tones. I would say that that's probably the most common. But again, looking at the furniture, making sure that it's anti-ligature and safe, but designed and set up in a way with these kind of insets of rugs and things like that to help with the noise. Noise on the wall or noise in the facilities tends to be an issue as well. I talk about this a lot when I'm helping design facilities, because we don't think about it, and we want nice tall ceilings and lots of natural light coming in with windows and things like that. But what that does create is that when you have multiple people in that space between staff and guests, it gets very loud. And so how do you take that into consideration in your design so that the space doesn't just look warm and welcoming, but it actually feels warm and welcoming, whether that's putting things on the walls, kind of sound barrier type things, streaming music that's softly playing, not adding to the noise, but helping maybe calm the environment, those types of things to help with the environment as well. Another kind of color palette, so I just wanted to show that, is the kind of maroons and tans in the color palette. And then I like this picture because it really shows what our staff island. So in these ones, you can see that we're empty right now. These are pictures taken before we open. So you can see the staff island in these different areas, right? That's the circular area. Here's what it looks like actually in action. So this is staff around that. And that's the goal, is that we don't want any barriers or plexiglass, which is often something that somebody wants to put up, or sliding windows, kind of where they can see out and they slide the window open to talk to the person that we're serving and that type of thing. You don't want any of those things. You want it to be, they need to have a space to work, yes. But you want that to be in a way that is still very welcoming and says that somebody can come up and talk to anybody that's up there at any given time. And then the goal obviously is that staff aren't behind the desk the whole time, they're out on the floor engaging with guests, but that is the kind of thought process behind that. And I think this picture shows a good view of just how all the interaction can happen that way. And so then some tips on maintaining. So what I will say is that it's not easy to develop and implement in the beginning. There's a lot of thought that has to go into it. I would say you're looking at things from different angles from a lot of different ways, bringing in people different so that you get different views on what that looks like, taking a break from those designs and then coming back and looking at that again, or making sure that you're getting feedback from the people that are going to be working in those areas. However, what I think is more challenging is maintaining a recovery-oriented environment. And so it's not one of those things, as we've learned, so this is kind of a lessons learned from us, is that it's not just an automatic that it stays that way. And so little things really make a difference in maintaining this recovery-oriented environment that sometimes we might think are not that big of a deal, but as I've been doing this for a long time, is really they really make a difference to staff. And when something makes a difference to staff in the sense that we're not listening, or they don't feel like we're reacting quickly enough to fix something, it really impacts their kind of drive to constantly want to do their best. So they have resources, they feel supported, they feel like there's a recovery oriented in the way they're treated. They're going to be more likely and driven to do that with others. And so really important to maintain the environment over time, making the necessary fixes and cleaning the environment. So one thing that we've learned is that we have to just plan for the little carpet inserts. We've done it both ways. We've had no carpet at all and just a solid floor. And then we've had the carpet inserts. I will say it's very much a homey environment when you have carpet in some places, although that means it's got to be cleaned regularly because you got a lot of traffic coming through there, and it's going to have to be replaced. And so making sure that that's just part of what you're planning to move forward, because if we're doing it reactively, like we're not thinking about like in 3 years or in a year or in 2 years, whatever that plan might be, if we're not putting that into our plan now, then we're going to be reacting when somebody's very disgruntled, very upset, you get guest complaints, things like that. You don't want that. You want it to be proactive and plan for that. So I always tell people, like, let's work that into what your upcoming budgets are going to look like, so that you're making sure that that's part of what you're tracking. And then fixes, like it's inevitable. Somebody's going to punch a hole in the wall or that type of thing, kick something, a chair is going to, kind of push into a wall and create a mark on there, that type of thing. And those little things really add up quickly. And so one of the things I always recommend is that what we've learned is to have someone who is readily available to do maintenance and to do it quickly. And that might look different for all of your different agencies and how you're connected. And if you have that already built into your teams because you're connected to a larger system, or if you have to do a local vendor and have that person available, or however that might look. But something really important that we've learned is something that you have to stay on top of so that the facility doesn't slowly start looking run down. Because as soon as it starts looking run down, it does not, no matter how much effort you put in, it does not look recovery oriented anymore. And it doesn't look like a home-like environment. And so making sure that we're staying on top of those things. Ongoing trauma-informed crisis training, as well as role specific. And so this is, of course, a given. We all know that we have ongoing training that we have to do with our staff all the time. And one of the things that I would say that we've found really helpful, so kind of a tip would be that really in-depth trauma-informed training is important to do annually. Not necessarily the training, and we have Relias, we love Relias. We have, it's a, learning management system where you put everything on. We do. I manage it. I totally promote that. However, I will say after 2 years of trying the trauma-informed care on Relias, I cut that and said, no, this has to be in person. And the reason being is because you want staff to be engaged in it. You want it to be this collaborative, engaging session so that you're talking through all the things that they are going through and how to mediate those things in a trauma-informed way. And so it's just a much richer environment when you can do those trainings and do it in person. Now, I get that it means time. It means somebody's got to cover the unit and take care of those guests that are being served during those times when you're pulling people off training and all of that, but well worth it. And again, if we plan it ahead of time, then we're being proactive rather than reactive. And we stay ahead of staff getting kind of run down, compassion fatigued, jaded, or resentful for some reason on those things, because we're pouring into them along the way, which is really important. Maintaining appropriate staffing ratios to the number of guests. So whatever that is for you all, it's important to maintain that and messaging that. One of the tips I would say is that it's really important how that's messaged. So for example, RI has regardless of our licensing requirement, which might be more lenient, they might have a 1-to-6 ratio or 1-to-8 ratio or that type of thing. RI is 1-to-4. We have 1 staff per 4 guests all the time. That's our ratio. Now that's our minimum. So if we have, we generally have run at our smallest facilities, we run 5 staff. So that not necessarily, we're over that ratio all the time in the sense that it's really like a 1-to-2 ratio. But the message we put out to staff and make sure that they fully understand is 1-to-4, because as soon as they drop down by 1 staff and somebody calls out and you have 2 hours before somebody comes back in and all that, they feel unsafe. And so it's really about them understanding and being very transparent with your teams about what is the staffing ratio, and then what are we going to staff up to, but that leeway in between matters, and that we could, be flexible within that. In addition, on the flip side of that, having a really strong capacity management plan that lays out when you're going to call in, when staff and your teams are empowered to call in extra help because you have high acuity on the unit, because 2 people came in and the provider really wants them on a 1-to-1 for whatever reason. And so that's pulling your staff from there. And so having a plan laid out for them to be able to, like I said, be empowered to make those decisions rather than rely on kind of a chain of command that has to take a long process for them, will help with staff feeling very validated in the work that they do and feeling supported to remain safe. Then the no force first philosophy. So one of the ways that I had already stressed that it's really important to maintain training and have staff really well trained. One of the tips that I would say is that what we've learned is that we have every year, all of our staff annually go through that full training again. That's the requirement on pretty much any restrictive intervention, de-escalation type training. But what we added several years ago was a monthly refresher. And we track it and make sure, because if we don't track it, then it won't get done. But we track it with all of our teams. And essentially what that means is that we take one aspect of that training whether it's a de-escalation technique, whether it's a restrictive intervention technique, whatever that is. And we all agree that that's going to be the thing that we're going to refresh on that month, and all of our staff do that. And so what happens is that they feel like they're constantly being trained and staying up on it, because like I said, when they're well trained, you use it less. So what also happens is that they might tend to forget how to use it properly. And so you need to continue to feed into them to train well, so that they can then continue to have that confidence and know when to use a seclusion room, when not to. We even, as a tip, because cameras are on the unit and that type of thing, we'll pull down different situations that have happened and go through those with staff during those monthly refreshers, so that we can talk through, not a punitive way, but what could we have done better? Did we miss a red flag that came up? Did we miss a potential trigger that was happening that we didn't catch? How can we catch it in the future? And this ongoing conversation is really, it helps staff feel more confident and also more open to talking, which again just lends to that recovery oriented feel of that they're being treated just as well as the guests that we're serving, right? We don't want them to feel like they have to suffer and their safety has to suffer so that we can do right by guests. We need to do right by guests, and we need to do right by our staff. And so helping them kind of have that is really helpful. Another tip, which many of you probably already do, but I think it's important. Sometimes I get new leaders that don't fully understand the importance of this, but weekly or bi-weekly one-on-one supervision check-ins with each staff. So however you structure, the leaders and the supervisors and all of that, but having staff have the ability to 30 minutes to an hour, depending on the position and all of that, have one-on-one undedicated or dedicated, uninterrupted time with their supervisor to just go through how things are going. Maybe we're talking about some new thing that's coming up or a new system thing with the EHR or EMR, that type of thing. But most of it should be about how they're doing. How are they holding up on their own? How, all of the debrief stuff that we would need to do, what they're doing really well, when they're using their skills really well, that type of thing. But having that time for them will help them stay, again, motivated to continue to provide the highest level of care for the people that we're serving. And then in addition, monthly all staff meetings, I think are really important at all levels, whether that's the call center, the mobile crisis, or the facility based, but bringing the entire team together on a monthly basis to talk through things that are going well, changes and things like that. Of course, those are always a topic of staff meetings, but really talking through some of the good stuff that's happening and pouring back into an employee recognition and those types of things. And then a planful approach to staff appreciation and recognition. Again, probably things that you guys are already doing. And what we've learned is that when we're not showing this regularly, and we have to be planful and mindful of it, otherwise it will not happen, because we all are very, very busy, and some leaders are better at it than others, right? So to bring everybody up to the same level, so that even those leaders that are not naturally good at doing recognition, they all have the same expectations, is to be proactive with a plan on what that looks like and how people are going to get recognized and who's going to be in charge of it and those types of things. But what we've seen is that when this begins to drop, and not drop by my standards, drop by staff standards. So we have to listen to our teams on what they feel employee recognition should look like, because it's different for different people. Some people like to have praise out in a all staff meeting. Some people like to have, a picture or kudos on the wall in the break room. Some do not like that. And so really understanding the team, because when we see this drop, we see staff that are less engaged. And when they're less engaged at work, for us, that means they're not providing the highest level of care to the people that we're serving. And so being less engaged really means a lot in this type of environment. And so making sure that we're pouring into them as much as possible. And then requesting feedback often from staff as well as guests. So we do satisfaction surveys at pre-discharge. So before anybody leaves, we ask the guests and they're anonymous, they go into a Survey Monkey, they do it on a tablet, all of that. But we then make sure that whatever we're doing we address those things. And there's a comment section. So any kudos that they're giving out to our staff, we blast those out, post them around our site, all that kind of stuff, so that staff really see that they're impacting the people that they're serving on a regular basis. But I would say those are some tips for us that we've learned over the years on how to maintain the recovery-oriented environment, because it can start to slip very easily if we get bogged down in the whirlwind of the day. And that tends to happen as in behavioral, because we're all extremely busy. And so being thoughtful and planful around that will really go a long way to help maintaining this recovery-oriented environment. And that's all I have on actual slides, but I wanted to make sure that we had enough time to talk through and hear your guys' thoughts and suggestions and questions and anything that I can help with. And there might be questions in the chat. I haven't been monitoring that because of my screen sharing, but yeah, Mandy.
Thanks, Amy. That was an awesome presentation. I am thinking about recovery-oriented language that's throughout the kind of day and interactions and all, like that's always been my kind of hope and expectation, but I noticed that it slips, right?
Mm-hmm.
And so I can write a policy about it. But one of my experiences has been when I challenge that, people, especially peer staff, say, like we need to talk, we need to vet, we need to feel like it's a safe place to say what we need to say to our coworkers.
Mm-hmm.
So what's your thoughts on countering that argument?
Yeah, I think it's a really great point and question, and I think something that probably all of us on the call, and I know I certainly have experienced myself with my own teams. And I think that yes, there needs to be, for other reasons, a policy and procedure written around how you treat people and all those types of things, for sure. How we make that happen, I think, is what I have seen really helpful is, yes, people need to be able to express themselves to individuals. There's always a way to do that still remains recovery focused. And sometimes people don't understand how to do that. And so one of the things that I would say is that ongoing training is really helpful. But I also have seen that when I or other leaders rephrase what people are saying for them, like in the moment when they say, and then I'll say, so really what you're telling me, and then I'll rephrase it in a way that's more recovery oriented. That modeling has seemed to be more effective for me and what I witnessed than this "you shouldn't talk that way" type of, like, it instead of it being like attacking of "you're doing it wrong," I'm just simply rephrasing what you said. And eventually what I see is that the people that really do care, and this is the thing, not everybody's going to jump on board with this, but from my perspective, and it's just my perspective, if they're not going to over time, they're not the right fit for working for me anyways. And so we kind of weed those individuals out naturally. But rather than it's "you did this wrong" or that type of thing, or "you hurt so-and-so's feelings by saying it that way," or that, is that we rephrase and we model. And you need a lot of people, right? So you need kind of your rock stars, is what I call them, throughout the program, so that people are constantly doing this, so that it's not just you as a leader that's doing it, but others are doing it well, and they're empowered to make those changes. And then in addition to that, I think that sometimes it does come down to, you actually do need to pull people together and have a conversation around how, when you say it this way, this is how that's making me feel, and having them talk it out, but with, kind of some guidance around that. Because sometimes I think what I have experienced is that people will say, "Well, you just took it wrong." Right? It's your issue. I didn't mean to say it that way. It's your issue for taking it that way. And that's a hard conversation too to have, right? Because yes, on one end, yes, that's accurate. But on the other end, we all need to grow and be better people about communicating. And so really kind of then turning it into, this is an everybody growth opportunity, not a you or you type of thing. And then I usually, when I see something like that happening and I have to pull people aside and have those conversations, then I just naturally weave in that in the next couple of weeks, we're all doing a training together. We're all doing something that, maybe they didn't think was on the books, but I knew was going to be on the books. And we're all going to have this conversation or bring in an outside person, because sometimes that's helpful. They hear things really well from us as their leaders. And then at times they need to hear same thing, but from somebody else, some expert in the field or subject matter expert or that type of thing, that they can then hear it in a different way so they understand that. But when I do that, I'm very strategic in that I'm letting that trainer know what I'm seeing, so that they can weave those types of examples into the training to help feed that conversation and kind of work through those things together. Does that help? All right, other questions, thoughts?
I've got another one if no one else wants to go.
Yeah, go for it.
Well, I've seen a lot of organizations that are really kind of, they're believing that they're trauma informed, or they're believing that they're really kind of progressive, go to these voluntary only staff meetings and staff trainings. Like, you get to do what, feels right to you as an employee. And flexibility is our, one of our values. And so, when you're talking about your monthly staff meetings and your weekly supervision meetings, are they mandatory? And do you say mandatory, or do you have some other kind of like progressive language that you use?
Oh, that's a great question, Mandy. Yeah, so any of you that have worked with me for any period of time know I'm pretty direct and transparent. I'm going to tell it like it is. So no, they are mandatory, and we call them mandatory because they're mandatory. So I'm not going to kind of think of a different word, and I apologize if that offends anybody, but I just want to call it as it is, and the expectation around that. And so for us, they are mandatory. We coordinate, especially for facilities, right? You have two different shifts. So somebody's coming in when it's not their shift or their day work. So we try and rotate it so that we're respectful, so it's not the same shift that's getting that all the time. So we plan it so that it might be the back end evening, and we're going to do it at the end of one shift and the beginning of another shift type thing. Or we'll flip it and we'll do the front end evening and catch those people. We have 2 12-hour shifts, so we can usually do it in the evening and catch that. And then we coordinate with our other teams to help support the unit while we're in that staff meeting. So then we talk about the reasons why I'm going to all those efforts to make sure that everybody is free to come. And then for us, we have a process that really you can only miss 2. So if we're having monthly staff meetings, that's 12. You got to make 10 of them before you're, and those reasons for not making the other 2 need to be cleared with the supervisor, meaning an emergency came up or you're sick, or, something like that. That's serious. But then we have a process set up in place that they are expected to then meet with the supervisor to go over that information, because they're still responsible to know what happens during that time. We did, for a period of time, allow for virtual attendance to help, because everybody went virtual, and so then we started using everything as virtual. I in my programs actually moved away from that again and made them in-person mandatory, because there was a lot lost in that virtual setting in the staff. The goal of the staff meeting, from my perspective, is to really build team cohesion and collaboration and friendships and relationships, so that you're trusting each other while you're working, or the other shift that's coming on or leaving, or that type of thing. And we weren't accomplishing that as well as we had been when we moved to virtual. And so again, I was really open with the teams and said, we're going to do this. And I gave them, the 30-day window kind of thing of like, we're going to have this is our last meeting. This month is going to be the last one that virtual is an option. And then after that, we're going to move back into it, and gave them time and all of that to address it, but move back to it. And oftentimes what I've found is that people understand that, and they're open to that, they get, they might be a little bothered by it in the beginning, but then they see the value in it. But I think that's also why it's really important, Mandy, to have a productive staff meeting. So if it's just a meeting to have a meeting, yeah, you're not going to want, people aren't going to want to, I don't want to be at meetings where they're just to have a meeting. And so having it where there's really some important topics that are like standing agenda items. We always go over safety stuff. We always go over things that HR might need to do, those type of administrative things, but then making sure that we're pouring into staff in two different ways. I always make sure that staff recognition, employee recognition is part of the all staff, employee of the month. They all come up with their own fun names for different categories, and we give those awards out during that time. And in addition to that, if it's an hour staff meeting, I have 30 minutes of administrative, and then I have 30 minutes of this employee type stuff. And so in addition to the employee recognition, some type of training. So whether or not we're staffing a case that we're going to go through and collectively talk through and see how we can learn from that, or doing a mini training, but in person, and a very kind of not me presenting at them or the leader presenting at them type training, but something that's more team building, or really collaborative, like a work group, so that they're gaining skills, so it's beneficial to them. And then I will say, hands down, I always feed them. So you want anybody to come to a meeting, feed them. So they always have food at those all staff meetings. And then the one-on-ones, the weekly stuff, I don't have the experience that people miss those. My experience is opposite, is that when those need to be canceled because of some crisis situation, they're asking, when is that going to get rescheduled? Because they really find value in having that one-on-one time with their leader, where they just feel heard and validated and told what they're doing well or what they could improve on, that type of thing. So that's usually not an issue. It's usually the all staff meetings that become that type of a challenge, but we're pretty clear with it. Yeah, Megan.
Hey, Amy, I was going to ask this question on behalf of Rachel, who says she doesn't have a microphone or camera on her computer. She was just curious about what kind of general turnover percentages do you see for peer staff and mobile crisis teams or stabilization centers, and whether there's much mobility between those peers who we work between the different components of the model.
Yeah, great question. And so turnover rates, I would say, especially now during that we've gone through this COVID pandemic, I think everybody's turnover rates are a bit higher than what they typically are. And we at RI average about the 30% turnover rate, which is a typical, kind of the low end typical for behavioral health in general. Individual programs, I have some that they don't have any turnover at all. The same team that's opened that program is the same team now. And so I think it really lends to the location and environment that's being developed, as well as the leaders and support that they get to really help with that. Generally speaking, people aren't leaving for, 50 cents more. They're leaving because they're already upset about something that's going on and they don't have a good relationship with their supervisor in some way. And so that's why I, from a leadership standpoint, always really teach my leaders, it's about that relationship and leadership development with them. And I will say, having a growth path. So one thing that we did see, even though we are international leader and peer support specialists, developed the curriculum and the training and all of that, we had a lot of people, a lot of peer supports that were leaving for various reasons. And we always do a, exit interview to figure out what's going on and how, if there's things that we can change, or if it was just a decision, somebody got a better opportunity, that type of thing. And what we were seeing is that although at a higher level in leadership, we very much thought that, yeah, peer support specialists can grow within the company any way they want to. They have to apply for jobs, things like that. At the staff level, they did not think that. They did not feel that. They did not believe that that was the case and all of that. And so what we ended up doing actually is a very open and transparent campaign around that. We're building a career path for and we did it for everyone. We started with our peer support specialists, but we did it for our BHTs, we did it for our milieu specialists, we did it for our clinicians, and so on. But we created kind of a path for them where we have kind of a level 1, 2, or 3 for peer support specialists. So just within that role, And then we have opportunities for team leads, depending on the program and the size of program that are a peer role. And so we made sure that people understood, and we kind of evaluated our current staff. Where do they fall, 1, 2, or 3s, based on the criteria that we came up with, and adjusted, pay and all those types of things. Got that straight with our current staff. And then as new staff came in, instead of everybody coming in at kind of the same level, if they had, a ton more experience, already certified, that type of thing, they came in at a higher level for that. And so that really helped a lot. In addition to that, though, we also made it very, very clear that a peer support specialist does not mean anything less than any other position. And so we talked through and had lots of work that we did where several years ago, we created a peer leadership council that our peer support specialists can work through, and it's led by our peer leaders in our company. We created a VP of peer specialist and empowerment, and that was Lisa St. George. She is now in that VP role and has been for several years. And then we also had opportunities where peer support specialists that actually had started in our programs became program supervisors over a variety of different programs. And when we made it clear that those things were happening and kind of announced, again, this employee recognition, right? Company-wide employee recognition or program-wide, it really started making a difference, because for us, we are so large and spread out in 9 different states that something in California, somebody in Delaware might not know that that's happening. And so really starting to share that information and be very open about, so-and-so was promoted into this role, and we're so excited because, and then tell a little bit of their story on how they evolved, like the ladder that they climbed within RI to get to that. That has really helped us with growing our career paths for all levels of our all positions, I would say, but in particular for our peer support specialists, so they know that they're valued. We had the same issue with RNs. We were losing really, really good nurse managers because they felt like they'd never seen a higher level leader that was an RN. It was always a clinician. Just happened to be a clinician. It wasn't that was anything reason for that, but until someone actually pointed that out to us and we said, oh, well, actually, yes, every one of them are clinicians. Why is that? And once we made it known and really kind of advertised for those next positions that RNs are absolutely qualified for that role within the job description and all of that, then we had more applying. And then when you have more people applying, you have better opportunity to kind of have a variety of different people in those leadership roles. But it was a feedback from our staff that they did not see things the same way that we did. And then we took that to heart to make some changes. I hope that answers your question. Any other questions? And I have not been monitoring the chat, but I'm sure that you all have. If there's any other questions in there.
I have a question, Amy.
Yeah.
I guess just thinking about how much of, infusing a recovery-oriented environment into your settings is really, just because it's part of the RI way versus, and now that you're working in so many different states, what is are you seeing states that have really robust regulation or, requirements around trying to support facilities, developing, recovery-oriented settings and these types of settings?
Yeah. That's a really great question, Becky. I think that what we're starting to see is that there's still a little bit of a disconnect in the sense of we're starting to see language be either through contract and RFP process, so that a process for bidding on a service and the contract with either your MCOs or whichever payer that might be, or some in actual licensing regulations on staffing requirements and environment requirements and things like that. That's less likely, although starting to happen with the rewrites that we're helping kind of guide, and but more so in the contract level, because MCOs, they really, want to have a trauma-informed and recovery-oriented, and they want peer support specialists on the team and those types of things. So we're seeing more where it's requirements or highly recommended that they're part of the team. The disconnect that I still see is that it's not tied to they're recognizing that this recovery oriented environment needs to be clearly laid out, that that's the type of, you don't want to over-regulate it and that everybody has to look the same, but you want enough in there that people understand what they're supposed to have as part of the environment. But on the flip side of it, from a staffing standpoint, what I've seen is that they'll say things like, we want peer support specialist or family support specialist part of your staffing pattern. However, in the regulation, they won't count peers as part of the ratio. So if your ratio is a 1-to-6, peers aren't included in that, and you believe you need 2 peers on the unit because of 16 to 20 guests that you're serving, at least 2 peers there, they're not counting that into your staffing ratio. And so then it's creating this situation where agencies have to then staff at a higher level than what is required of them, and lose money because that high, right, salaries is your largest part of your budget, and kind of function at a loss in that way. Or the first thing that gets cut is the part that's not part of the ratio. And so I see that disconnect happening. So I think I always say, like, they're making efforts and it's getting there, but we're not there yet where it's part of that. And so one of the things, for example, I have in California, very much recovery oriented state. They very much believe in peer support work and all of that. However, they don't include it in any of the ratios. And so you have to staff to hold to contract. You have to staff at this level. You only get reimbursed at this level and this ratio. And so you're constantly losing money. It's just the way you function in California. And that's not okay. That's not a sustainable future. And it's really not going along the guidelines. I mean, CMS recognizes peer support specialists as behavioral health professionals that should be reimbursed and be able to use codes and all of that. If CMS is recognizing that, then all the rest of the states need to come along and figure that out as well. And so, so we're making progress, but we're not there yet. We're not there yet. I have more to go on the parity issue around that. Any other questions? No.
Well, if there's no other questions from the group, I think we can go ahead and wrap up. Thank you so much.
Actually,
for your...
I'm sorry.
Ivy. Yeah.
No, this is Lisa Dowdy. I'm with. So I have a quick question. I don't recall that we've talked about at all what kind of outcomes the consumers are experiencing because of this different approach. So I work in a hospital as well, and oftentimes we see these people coming back over and over and over again because they're not getting trauma-informed care. So I'm just curious if you have any numbers or research on that, because I would think that this would be much better for the people.
Yeah, no, that's a great question, great point. We absolutely track that. So we track it from a few different ways, right? We have ongoing, while somebody is in our care, we have what we call the engagement tool. And it's essentially same time we do vitals twice a day, once per shift. And we do this engagement. We call it the engagement vitals tool. And it's about whether or not someone is feeling cared for, and if they're feeling part of their treatment, and that gets recorded, and we make immediate adjustments if someone is not, and all of those things. We also do the guest satisfaction survey, and everybody gets that. And if they decline, they can decline, but we have to note that. But we take that very seriously as well, meaning that if we saw 500 people that month, then I want 500 either surveys or declines, right? Like everyone is accounted for, and I'm going back to the team if one is missing, because it's really important feedback for us to continually look at and making sure that we're looking at the comments and those types of things. And then from our perspective, we're also tracking recidivism rates. Now, the challenge here is that we don't have access to everybody else. And so we're tracking recidivism based on whether or not they're coming back to us. In some situations that is very valid data, because we're the only crisis facility in the area. And so they would come to us or the emergency room anyways. And so it gives us a little bit of information, but we're missing it if they're going to the emergency room. But we do track that. And what we track is how many times somebody might come back to us within a 30-day period. And the reason why is because we want to make sure, and we have an approach that if they're coming to us again within that, then we didn't do a good enough job resolving whatever crisis that they were going through at that moment. And so then we pull together teams to help try and work through that and figure out what did we do, not what did they do, or how come they relapsed or whatever. It's not theirs. We look at it as it's our issue. And what did we not do well enough, or did we not engage well enough, or at the level that they needed us to engage, whatever that level might be. And we look at those things. And so we have those collaborative meetings continually to address those things as well. In addition, the communities, we build really good collaboratives within our community so that we can talk through some of that as well with people that are, we call them friendly faces. Some people call them high utilizers, or familiar faces, that type of thing. We could say friendly faces, people who, because we don't want to ever turn anybody away. And so we're going to accept every time, but what's going on? Why are they continuing to come back, and how can we help them? Overall, though, to your question on outcomes and in comparison to hospital settings, typically the only time we have that kind of data, which is significant, is when we're first building a crisis facility for the first time in a community, because the result is how much of an impact did we have on jail and emergency room, right? Our goal is to divert individuals from going to those two places. And so in the beginning, that's the best account that we can have is have we decrease the number of people going to the emergency room and to jail, and then tracking those percentages. But over time, when the system is really built and all of that, then what we look at, we flip and look at, are there spikes? And then what are their spikes for? Like if we had more people going to the emergency room, what was that? Was that because something happened at one of our crises? Not necessarily ours, but we have multiple crisis partners in the area. Like, is that what's going on? We come together as a community of stakeholders to figure those things out. Definitely worth tracking and making sure that we're working on that.
Thank you. I appreciate that.
Yeah.
Great. Are there any other questions for Amy?
Yeah, I have one. If one of your guests wants to just walk out and leave, but you guys feel that they're a danger to themselves or could be a danger to someone else, what's your guys' approach, or
Yeah.
how do you take care of that? And then similarly, if there is a guest who is violent towards someone else, do you rely on the police department, or do you guys have some sort of security that kind of takes?
Yeah, great questions. So first one on, can they leave against medical advice? Yes, if they're voluntary. However, all of our facilities are locked. And so someone can't just walk out in the sense that they say they want to leave and they can just walk out the door. But we also want to honor that if somebody wants to leave and they are voluntary. And so with us, it's really about engaging the team with them to help figure out, why is it that they want to leave? Are they upset about something? Can we help resolve something? Helping explain the process of discharge. We still have to discharge them and help set up good transportation and all those types of things. And really working as a team to really help that individual calm down enough to know. And if they still want to leave, we're still working that process with them. And then making sure that if needed, that appropriate people are notified of that if it's warranted for those reasons. Otherwise, knowing that they can turn around and come right back in if they want to, and they'll be welcomed in. For the violent piece, all of our staff are trained in restrictive interventions process and de-escalation techniques. And we have a seclusion room and all those things in every one of our facilities for that reason. We don't rely on police. For one, we don't have security at any of our facilities. We don't believe that security should be part of this. It takes away from the recovery oriented environment. And actually, from our perspective, our staff, our team of multidisciplinary people are trained to be able to handle those situations. And so we never need to utilize security. And so we don't have that. Even when people want that part of our contracts, we say, no, that's not our way of doing things. And then we usually have to show them that it'll work, and it does. And then they lay off that ask. One of the things though with police is that because we build such strong relationships with them, they understand that we're going to have well-trained staff that are going to take very highly acute individuals, could be aggressive, could even be aggressive right there in the Sally port with the handcuffs on, that we're going to accept all those individuals, because what we know is that the majority of the time, and I would say this is probably like 99% of the time, they're going to calm down and be able to engage with us as soon as that law enforcement officer is off the premise. And our law enforcement teams know that if we are calling, we call so rarely that if we are calling, it's truly a situation that we cannot handle, and it's gotten to that point. But that is a very small percentage. We track that at all of our programs because leadership wants to know if somebody's, it's a partnership that we have. So we don't want to ruin that partnership, but we have an obligation that we've committed to serving the guests that we're seeing. And every time you bring law enforcement into that, even if it's not for that individual, it's a traumatizing experience. And so we want to avoid that as much as possible. So we track those things, and then they do know. So I will say that we've had to do that a couple of times over the years, and they just know that if RI's calling them to come back for some reason, it's a serious incident, and they're there very, very quickly resolving the issue for us.
Perfect. Thank you.
Mm-hmm. Mm-hmm. All right. Well, if there's nothing else, then like Becky said, we can wrap up. Our next webinar for next month will be trauma-informed care with our very own Dr. Kevin Huckshorn, which some of you might be familiar with as well, because she's done some work up in Alaska. So she's going to do a training on the importance of trauma-informed care in a crisis setting. And so I'm really excited for that training for you all as well. So know that, come back for the next one and tell everyone else as well.
Thanks so much, Amy. Thanks everyone for joining. That next webinar will be February 16th, and you'll be getting the registration link as well as the link to the recording from today next week.
Excellent. All right. Thanks, everyone. Have a great day.
Bye-bye.
Bye.